Hey, good afternoon, everyone. I'm going to do a brief video on reviewing a couple questions on the Cardiopulmonary Quiz and then reviewing for the final exam. In the past, I've had class on Monday a couple times, and we're not having class tomorrow on Monday. This is Sunday afternoon. But I wanted to spend a little bit more time than I had last Thursday to review the final, so I'm going to do that right now. Hopefully, Owen will be able to get that on our 120 YouTube channel, or we'll put it on Facebook in our class. Okay. So the Cardiopulmonary Quiz, particularly, I wanted to review the last two questions, which were question number 19, described how the Borg's rating of perceived exertion scale and the metabolic equivalent levels are used in exercise and cardiac rehabilitation. A couple of you, I think, got this fairly well, but a few of you missed the mark. The Borg's rate of perceived exertion, we know it's a subjective questioning, and it gives us as cardiac rehab specialists and physical therapists a way of guiding the intensity that the person thinks that they're working. And normally that correlates very well with heart rate. The original Borg scale was 6 to 20. We had talked about that being 6 being very close to a heart rate of 60 beats per minute, whereas 200 would be up to, or 20 would be up to 200 beats a minute. And so they use that in cardiac rehab to guide the person's subjective feelings of intensity. The other one, or the new scale rather, the modified scale, was 1 to 10, which just made it, somewhat correlate to the 1 to 10 pain rating, and which is why they use that. The metabolic equivalent level is something different. It is a guide and or a scale related to how much energy exertion that a person has to use to do particular activities, such as walking, shaving, daily activities. Obviously, something like washing your face and hands, much lower MET level than shoveling snow. And so what we like to do, or what we use the metabolic equivalent levels for, is to help guide a person in the level of activity that we as professionals feel that they are safe to engage in. So it is a more objective scale that has been researched, and we know that if a person is in, let's say, phase 1 cardiac rehab, we don't want them doing activities that they'll exert too much effort and therefore put too much stress on the heart. So usually very low level activities in phase 1, and that progresses to phase 2 and phase 3. So both of these scales are used to monitor and to help a patient safely progress in cardiac rehabilitation, and they're used across the board. The second question, the 16-year-old cross-country runner is referred to the clinic where you're employed with a diagnosis of right ankle sprain. So that's its primary diagnosis. His weight variance is tolerated, right lower extremity is on 1 to 2 crutches. Following the PT evaluation, you must provide the treatment to address the patient's desire to return to competitive running when able. His heart rate is 40 beats per minute, which is fairly common for someone who's involved in that type of activity and has no other past medical history. And the reason this question was on there is because I really wanted you to be able to put together all these components of fitness as it relates to physical therapy treatment. A couple of you guys really got off the path here on this one. Some of you focused primarily on the ankle rehabilitation, which was important or is important, but it's not in regards to their cardiac rehab. Other people, forgot, that they had an ankle problem and had them running on a treadmill, which they couldn't do. So we definitely needed to think about both of those issues. Discuss the concept of deconditioning and the energy systems utilized. Remember that there was specific information in Chapter 7 about deconditioning, and it was pretty much related to maybe older patients who are debilitated, but we know that there is significant decrease in cardiac output, a decrease in their endurance, a decrease of strength, a decrease of muscle mass, and others that would affect this particular patient. And so we wanted to realize that, but the number one energy system that this person is utilizing in distance running, of course, is the aerobic system. And so when we are trying to help them return or maintain their fitness level, we have to do a considerable amount of aerobic activity along with their ankle rehabilitation. I'm not going to speak to that specifically, but I want to talk to you about the specificity, which is question B. Discuss the concepts of specificity and how it relates to the patient's goal. we know that we have, we talked about the SAID principle, we talked about the overload principle. So in this case, we have to be able to do something to maintain this young person's cardiovascular health, such as swimming, stationary bicycling. Those would be two, maybe upper body ergometer, try to get their heart rate up. But realize this person has probably been running five to 7 days a week, maybe upwards of an hour to longer every day. And so that's the level of time and intensity that we have to keep them at. Swimming would be fine if they can swim. We know that it's not specific to running, but at least it helps to maintain their cardiovascular fitness. And as soon as we can, there was no fracture, then we can get them on an elliptical, for an example, and hopefully progressing. Someone put on there, a treadmill where you can take their weight off, and that would be a great opportunity if you had that. So the time and duration of exercises should the patient be involved in. The time, when we're thinking about the cardiovascular system, is again going to relate to how much have they been practicing. And assuming this person is late in the season, they're probably, again, been running, minimum of 30, upwards of 60 minutes at a time. So we can't have them doing 15 minutes of activity, or it's not going to maintain their cardiovascular fitness. So time relates to what they've been doing in the past, of upwards of 60. The type of activity, again, we want it to be running, but it can't be right now because of the ankle sprain. So we're going to focus primarily on non-weight-bearing activities, or at least partial weight-bearing activities. And even when you're stationary bicycling, there's a little bit of weight through the lower extremity, but probably very tolerable for an ankle sprain. So considering that. D was very important, the frequency and the intensity. Well, again, the frequency should be correlate with how much they're actually exercising right now during the cross-country season. So probably 5 to 7 days a week that you need to have them doing their activities. And the intensity, of course, is related very much to heart rate. This individual, remember, we talked about 60 to 80, 85% being kind of that normal range for target heart rate, whereas our deconditioned patients, elderly patients, may be somewhere in the 40%. This individual is probably a 16-year-old healthy individual with a resting heart rate of 40. He's going to probably be able to tolerate upwards of 90% of his maximum heart rate, which would be his exercise heart rate. So that question, I specifically wanted you to think about their heart rate, not necessarily how many repetitions they're doing for their tubing exercises for their ankle. Provide rationale that you would explain to the patient that helps them understand your plan. There, I just wanted you to focus on the whole idea that what we're trying to do is maintain your cardiovascular health while we rehab your ankle, so that we don't lose that. Once your ankle's better or improved, then we can get you back, running, and hopefully not miss much of the season. So, I put these questions represent critical thinking and problem solving, and are you ready for the clinic? So really think outside the box. Remember that all of your patients should be involved in some type of aerobic program. This individual, very much so. All right, so I'll get those. I've got a couple more to grade, but I'll get those online probably before you even watch this. All right, moving on to the second objective of this video is to review the final study guide so that you're ready for your final on Wednesday. Remember, that's going to be Wednesday at 2 o'clock, I think. I think so, sorry. The questions, there's 100 questions on the exam, and there are 37 old questions and 63 new questions. So I put, 60 and 40%. It's close to that. There's about 37 old and 63 new, okay? And, I start off with general exam content, the effects of heating and cooling, types of thermal agents, and obviously we talked about hot packs and cold packs, and we covered that in week 1. The procedures in those boxes, in those chapters, the how-to boxes or application procedures, make sure you read through those. Make sure you're aware of safe temperatures to use hot packs, for an example, and how many layers of toweling, such as that. The next bullet point is pain, and we definitely covered pain. I think it was our second chapter, and it's a common reason, if not the most common reason, that our patients come to see us. And so we have to understand pain to some degree, but also this semester was focused on physical aging. So how can we help patients reduce their pain. And so go through that chapter as well. Diathermy and ultraviolet effects. Make sure that you are looking at the minimal erythema dose. There's a couple questions on that. Indications and contraindications of all physical agents. There are several questions over that, so make sure that you review that. And that's a big topic in regards to state board questions. So the more that you study that, the better off you'll be. There's not a lot on skeletal anatomy, but there may be a little, particularly on different systems and how, as we think about cardiovascular health, for example. Traction, effects, purposes, types of diagnosis used for. Remember, we primarily use traction for cervical and lumbar and disc pathology. We can do manual traction, mechanical traction, and it helps to decompress the nerve root. And we talked about McKenzie exercises versus Williams flexion exercises. Remember, the McKenzie exercises are primarily used for disc pathology as well, where we have radicular pain. With McKenzie exercises, we're doing extension bias activities, pushing the disc forward and reducing pressure on the nerve root. Williams flexion exercises are primarily used for patients who have spinal stenosis, which is a primary diagnosis, or someone who might have a spondylolisthesis. In that particular case, we are pushing the disc backwards and opening up the intervertebral foramina. Make sure you review dermatomes for upper extremity and lower extremity, and that wasn't too long ago, so it shouldn't be too difficult. Different diagnostic tests that we reviewed this semester, their purpose. Body substance isolation and infection control from your patient care textbook. Review that. I put pathologies covered. Obviously, we covered quite a few of them as it relate to the use of physical agents, but particularly pay attention to peripheral vascular diseases, deep vein thrombosis, diabetes, insulin or type 2, type 1 diabetes, varicose veins, cardiopulmonary pathologies, as we've recently covered. Okay, manual muscle testing, and there are a couple questions on manual muscle testing in regards to muscle grade definitions and the different positions you put them in for 3 through 5, and 2 through 1. Types of wounds, as we looked at peripheral vascular diseases, and we covered diabetic wounds, neuropathic wounds are the same then, or pressure ulcers, pressure wounds, versus venous wounds versus arterial wounds. So look at all of those. When we talk about pressure wounds, think about staging of those types of different types of debridement, such as selective and non-selective debridement, and the stages of healing as we progress. Proliferation phase, for example. Therapeutic ultrasound, what are the effects? We heat by conversion, remember, converting electrical energy into sound energy. The difference between continuous and pulse ultrasound. With pulse ultrasound, of course, you get the benefits without the heat. 1 megahertz versus 3 megahertz, and when would we use one versus the other? Remember, 3 megahertz heats up not quite as deep, so you can use it on thinner tissues. Intermittent compression and edema control. Look at circumferential measurements on how to do that and the purpose of. And, we talked about lymphedema, so review that information. We spent quite a bit of time focusing and emphasizing inpatient or bedside treatments. And so review that chapter in your textbook, as well as the PowerPoint and the handouts from lab that Owen has given you as we did our sim lab. Okay, tubes, line catheters, chest tubes, Swan-Ganz catheter, those type of things, just be familiar with. If you look at the SimMan handout that I gave you, that would be good review as well. Okay, hydrotherapy, physical properties of water, the effects of hydrotherapy. We had a couple good presentations in lab regarding the benefits of hydrotherapy. But remember, we can use it as an aquatic device, or actually in a pool where the whole body's in there, and that's important for reducing weight-bearing structures, or weight-bearing stress rather. But also can use hydrotherapy for wound management. Burns, treatments of risk factors, primarily infection because of dehydration, the exposure. So larger wounds and there's a larger or a bigger potential for infection. Okay. We did talk about evidence-based practice, and so review that one chapter PowerPoint that I went through, the different levels of evidence, and remember we looked at randomized controlled trials versus having multiple randomized controlled trials, trying to find the best evidence that you can. Hopefully that experience, looking over the APTA information and using the library and the resources, helped with that process. Cardiopulmonary content, and that was our cardiac lecture, and then chest physical therapy or pulmonary rehabilitation as well. A couple of you, and I'm really talking to myself here, but a couple of you, as I looked at that survey that you filled out recently, I went over the results of that, and a couple of you put down that we didn't cover cardiopulmonary content very well. And first of all, let me apologize if you felt that way. It definitely wasn't something I was trying to do. I mean, I know that a lot of things get crammed into the end, and it sometimes feels like we skim over it, but that wasn't the point. And in fact, it was just the opposite. I think maybe we had done that in the past, but at this point in time, we're trying to be more thorough over the content of cardiopulmonary information. So go back and review. We gave you several slides. There were handouts for you. We talked about it. At least I thought we did to a great extent. And then lastly, which is, you're going to get 63 new questions over cardiopulmonary content and electrical muscle stimulation. So make sure that you get in and look at that. I put more specific information, review handouts, that I've given you both for cardiopulmonary or for electrical stimulation. For eSTEM, there's chapters 11 through 14, and for cardiopulmonary, chapter 6 and 7, and then chapter 25 in the Colby-Kisner, and that chapter 25 was a handout. And then cardiac and chest physical therapy PowerPoint, so make sure you look through those. All right, second page of your study guide. There is the first half of it primarily is over eSTEM information, and the bottom bullet points are primarily cardiopulmonary information. So appropriate wavelength selections for stimulating muscle, and we looked at the use of NMES, or let's say Russian stimulation, for muscle contraction, and those are there are several indications or reasons why you might want to stimulate a muscle to get muscle contraction, and normally that is muscle strengthening or muscle reeducation, or possibly the reduction of muscle spasm on the antagonistic side. The strength duration curve, I mentioned that in our PowerPoint, but it's also in the chapter reference, so make sure you're looking at that. But obviously, we stimulate. When we stimulate we put an electrode on and we stimulate the skin. For example, because of the smaller nerve fibers, such as a sensory nerve fiber, you're going to feel it well before you see muscle contraction. And so it takes a higher level of stimulus, a higher intensity or amplitude, as well as an increased rate. So pulses per second or frequency is going to have to be greater. And when you do that, when you continue to increase that, then you're going to stimulate those larger nerve fibers and you're going to get muscle contraction. So, and as we think about action potential, those nerves have different action potentials. And the higher the stimulus, or the greater the amplitude, the higher the pulse rate, the more potential to get muscle contraction. Okay. The relationship between current density and electrode size and symmetrical versus asymmetrical waveforms. Again, look at the graphs and the photos in your text and the PowerPoint. That'd be helpful. But current density, that just represents if you had two electrodes, the larger the electrode would have less current density. Said differently, if I was pushing X amount of electrical current through two different electrodes, the smaller the electrode, the greater the current density. So if you had a large electrode and a small electrode, and the large electrode is sometimes called the dispersive electrode, and you really don't feel it underneath that one. whereas the small electrode is the one with greater current density, and you'll definitely feel it there and have a more, if it was high enough, have more muscle contraction underneath that electrode. Okay. Remember that when we're trying to stimulate for muscle contraction, we're actually trying to put that over the motor point where the nerve innervates the muscle, and it's usually in the muscle belly area. Okay. Symmetrical versus asymmetrical. We looked at the different waveforms. Remember that alternating current typically is in a sinusoidal waveform. So there's the positive phase and the negative phase have the same amount of current. So there's no net charge. But when you have asymmetrical waveforms, you can potentially have a positive or negative charge left in the current. And that's what that is. A symmetrical curve or symmetrical waveform, you're going to have the same amount. Okay, they're going to look the same. So look at those pictures. Be able to identify pulse width, amplitude, and various waveforms as used in diagrams and textbooks. Also look at duty cycle. Remember, duty cycle is a relationship between the total time on and the total time, which would include your time on and your time off. So look at that. Tetanic contractions. A tetanic contraction basically is a contraction without relaxation. We might think of that as a cramp. And when we did our 10-second Russian stimulation, you're definitely using a tetanic contraction. So you're contracting that muscle for 10 seconds and really getting a good contraction, and that creates the most benefit, if you will. And we know for a tetanic contraction, we need a high enough amplitude, a large enough pulse width, and a high enough pulse rate or frequency. And normally you're going to get somewhere over that 25 to 35 pulses per second with a high enough amplitude, and then you'll have a contraction. Okay. Make sure you review contraindications. Probably the number one contraindication for electrical stimulation, remember, is a pacemaker. So make sure that you're aware of that. Make sure you look at all the different definitions. We covered many definitions, not only in your PowerPoint, but I emphasized at the end of each chapter. So Rio-based, chronaxy, pulse frequency, pulse duration, ramp, the different waveforms such as interferential current, high volt pulse current. Okay. We looked at use of polarity. There's positive, negative polarity, as I was just talking about, whether there's a charge left in the skin or in the tissue. And we looked at the use of high volt pulse current for wound control. And when we're in the infected or inflammatory phase, you use negative. In the healing or proliferation phase, you're going to use positive. Okay. We looked at NMES, neuromuscular electrical stimulation set up for muscle strengthening. Muscle in your PowerPoint, or I'm sorry, in your study guide here, it says muscle reduction. What that means, muscle spasm reduction. I'm sorry, I left out a word. Excuse me. So muscle strengthening, as we look at the one for in your lab scenarios, we're doing dorsiflexion on the anterior tibialis. We're trying to simulate muscle strengthening, and we could also use it on the quad. You can use NMES very much like you do Russian. Muscle spasm reduction, when we used the one where we were trying to reduce the wrist flexor spasticity. So what we did, we stimulated the antagonistic muscles, which would be the extensors. We used a nice slow ramp so that we didn't get that stretch reflex, and we got the flexors to relax, and we pulled the forearm into a neutral position, which might be more functional. Waveform accommodation. Accommodation just means that your body is accommodating to it and you don't feel it as much, or you don't get the response you're looking for. We prevent that by modulating, such as the interferential current goes from 80 to 150 pulses per second, and it ranges and back and forth. And as it does that, the person doesn't accommodate. Okay, and with the TENS unit, sometimes you have to turn it on or turn it up frequently because the body starts to accommodate to that. We talked about iontophoresis. Remember that your milliamp minutes, the dosage is typically 40 milliamp minutes. Sometimes it can be 80, but normally it's 40. The effects of direct current and how to set it up for treatment. Remember that with direct current, it's a unidirectional, meaning that it doesn't alternate back and forth, and it can be positive or negative, and you can have pulsed direct current, so you can shut it on, turn it off, but you can shut it off and turn it back on. When we did direct current with the iontophoresis, remember you had like a burning feeling, which is pretty common. Tissues high and tissues of high and low impedance. Impedance just means the resistance to electrical flow, and where you have hair or oil all over the skin, the electricity doesn't penetrate as well. And so normally if you shave the skin, use a little bit of moisture, so those a lot of the electrodes have somewhat of a water-based adhesive on it, and it helps to stimulate that better. Muscles and nerves stimulate pretty well. Fat and or bone, for an example, has quite a bit of impedance to it. Relationships of parameter selection to fatigue. Anytime that we have muscle contraction, electronic or from an electrical stimulation, remember that we talked about it stimulates the large fibers first versus small if it's done physiologically. So using electrical muscle stimulation, electrical current for muscle contraction, you're going to have quite a bit of fatigue. So we can try to reduce that by, number one, giving them a long rest time, and that goes to your 10 seconds on, 50 seconds off Russian stimulation, but also low rate. You really want just the minimum amount of current and frequency to get the contraction or the desired results. So low frequency and long rest time is going to help with fatigue. Pulse frequency, remember, is also rate or hertz, and pulse duration settings for your high and low tens. Your high rate tens is going to be more of what we call the traditional or conventional tens, and I think we said like 125 pulses per second, whereas your low rate tens, which was we called a burst mode, was primarily used for a lot less time, like 20 or 30 minute treatment, and lower pulse duration. Okay, moving on, the rest of the bullet points are primarily related to cardiopulmonary, except for the last one, which talks about exercise. So the QPRS T wave, so looking at the rhythm, a cardiac electrical rhythm, or the strip, understanding where we have atrial and ventricle activity, the small little bump on the left versus the QRST wave, which is the peak in the center, represents your ventricular polarization versus repolarization, and the small little beginning hump on this strip will give you the atrial activity. So look at that. Look at the handout that I gave you, as well as in the PowerPoint, parts of the ECG or EKG complex. Cabbage coronary artery bypass graft, why do they do that? What are some of the restrictions? What are some of the risk factors for someone who might develop coronary artery disease that might end up with a cabbage? Look on your Ann Downs PowerPoint as well. Normal and abnormal cardiac and respiratory vital signs, that's going to be important for you to understand. Primarily looking at, from a sim lab and the values that Owen handed out. Cardiac rehabilitation, particularly our when to stop exercise with a cardiac patient. Look at the handouts that we gave you, again, from the Ann Downs handouts, as well as the one that I gave you in lab that talks about cardiac rehab, a cardiac profile, talks a little bit about cardiac pathologies and when to terminate exercise, when to stop cardiac rehabilitation. Symptoms related to myocardial infarction, a difference between high and low density lipids, and remember that high density lipids are considered to be healthy or good, low density lipids unhealthy or bad. Types of exercises used in cardiac rehab, and particularly cardiac rehab phases, phase 1, phase 2, and phase 3, are when phase 1 during the hospital, phase 2 and 3 are outpatient, phase 4 is when they are discharged completely and they're doing it on their own. Remember that we use the Borg scale and the metabolic equivalent levels to guide that. Okay, looking at pulmonary rehab, types of breathing, such as pursed lip breathing and diaphragmatic breathing. How do we do that? Why do we do that? Other exercises as well from a pulmonary standpoint. What is exercise heart rate? Chapter 7, make sure you know that Kavorian's formula and how to calculate not only your maximum heart rate, but your target heart rate zone. And notice that from a deconditioned patient, you may be using a heart rate zone in the 40% of that maximum, or someone who, like the 16-year-old cross-country person, might be more in that 85 to 90%. So make sure you know how to do that. Cardiac and chest pulmonary anatomy, not a lot on there, but particularly the muscles of ventilation. What muscles are used during accessory motion versus passive, or accessory breathing, or secondary breathing versus passive primary breathing. Again, different types of breathing, respiratory capacities and lung volumes. Make sure you know the difference between obstructive and restrictive lung diseases, and how with obstructive lung disease your actual lung volumes increase, but we have more air trapped in, so our residual volume gets greater as well. With the restricted lung disease, remember that the lung volumes get less. Okay. Postural drainage techniques and positions. Remember, postural drainage primarily is related to gravity and different positions to help drain over time. But normally that's combined with percussion, vibration, and shaking. Make sure you know what position to put them in, how to do, what patients might be contraindicated in doing that. Also, the importance of an effective cough, and if patients can't cough after postural drainage and percussion, that it's not going to help them significantly. So we have to have a good cough. Make sure you know how to teach your patients to cough better or more effectively. Review again different pathologies, both in pulmonary and cardiac. And this last bullet point in the therapeutic exercise book, Chapter 6, not 7, but Chapter 6 reviews resistance exercise for impaired muscle performance. So this is something we covered at the end of last semester, but there are a few questions on this exam, looking at the difference, the general principles of exercise, the types of resistance, isometric, isotonic, isokinetic types of contractions, concentric versus eccentric. And I even go as far as saying review your therapeutic exercise lecture over therapeutic exercise in the last semester. Looking at the DeLorme's, Oxford, the DAPRI techniques, which are all strength training and resistive training activities. Reviewing the SAID principle, the overload principle, will be helpful as well. So this exam is, like I said, 200 points. It's 100 questions. Most of it is over new material, cardiopulmonary and electrical stimulation. About 37 to 40% of it is over new or older general material. All right. It'll all be worth, every question's worth 2 points. There is no fill-in, there is no essay or short answer. Everything's multiple choice. I don't even think there's any true faults, but don't hold me to that. But I think they're all multiple choice, kind of getting you ready not only for Natalie's 210 class, but also for your state board exam in just a year or so. So anyway, I will be in my office and available Monday and on Tuesday, or even Wednesday morning. Please feel free to email me, text me, 812-887-8431, or call me if you have questions, and I'll do my best to answer them. But I'll see you on Wednesday for the final exam. Thanks very much.